Bismillahirrahmanirrahim. Today we will have case quiz number 23. Case data: 2-month-old female neonate. Her mother recognized that something was not quite right. General symptoms of fever, fatigue, irritability, and malaise. There is something error, but no history of trauma. Examination revealed left leg, some localized edema and erythema. On palpation, the baby appears to have pain overlying the proximal tibia. Passive manipulation shows a full range of movement of the leg without any obvious indication of pain. Investigation: CRB markedly elevated, ESR elevated, CBC normal. X-ray showed. This is the X-ray of this neonate. As usual, we can stop here, enlarge this X-ray, and you can answer after this. So, what is the diagnosis? The answer is acute hematogenous osteomyelitis. Acute hematogenous osteomyelitis. Acute hematogenous osteomyelitis. Septic ascites is less likely in view of excellent range of motion. There are two principal types of acute osteomyelitis: hematogenous osteomyelitis and direct or contiguous inoculation osteomyelitis. Acute hematogenous osteomyelitis is characterized by an acute infection of the bone caused by the seeding of bacteria within the bone from a remote source. This condition occurs primarily in children and neonates. The most common site is the rapidly growing and highly vascular metaphysis of growing bones. Direct or contiguous inoculation osteomyelitis is caused by direct contact of the tissue and the bacteria during trauma or surgery. Clinical manifestations are more localized and tend to involve multiple organisms. Predisposing comorbidities include diabetes mellitus, sickle cell disease, acquired immune deficiency syndrome, AIDS, intravenous drug abuse, alcoholism, chronic steroid use, immunosuppression, and chronic joint disease. Other possibilities are the presence of a prosthetic orthopedic device, recent orthopedic surgery, or an open fracture. In general, osteomyelitis has a bimodal age distribution. Acute hematogenous osteomyelitis is primarily a disease of children. However, direct trauma and contiguous focus osteomyelitis are more common among adults and adolescents than in children. Spinal osteomyelitis is more common in individuals older than 45 years. The bacterial pathogen varies on the basis of patient's age and the mechanism of infection. In neonates less than 4 months, Staphylococcus aureus Enterobacter species and group A and B Streptococcus species. In children from 4 months to 4 years, also Staphylococcus aureus, group A Streptococci, Haemophilus influenza, and Enterobacter are the most common pathogens. In children and adolescents over 4 years to adults, Staphylococcus aureus is the most common, 80%, group A Streptococcus, Haemophilus influenza, and Enterobacter similar to those of children. In adults, Staphylococcus aureus and occasionally Enterobacter or Streptococcus species. Responsible pathogens may be isolated in only 35 to 40% of infections, which means that more than half of the cases we cannot isolate the causing organism. With direct osteomyelitis, the organism includes Staphylococcus aureus, Enterobacter species, and Pseudomonas species. In the presence of puncture wound, there may be Staphylococcus aureus and Pseudomonas species, and in the presence of sickle cell disease, Staphylococcus aureus and Salmonella species are the most common. Appropriate antibiotics are selected using direct culture results. Empirical therapy is often initiated on the basis of the patient's age and clinical presentation. Further surgical management may involve the removal of the needles of infection and implantation of antibiotic beads until resolution of the infection. Plain radiographs may show evidence of soft tissue swelling after 3 to 5 days. Bony changes are usually present at 14 to 21 days. The earliest bony changes are periosteal elevation followed by cortical or medullary lucency. At 28 days, 90% of patients demonstrate some abnormality. MRI is effective in the early detection of osteomyelitis with a sensitivity ranging from 90 to 100%. Radionuclei- Radionucleic bone scanning using a three-phase bone scan with technetium 99M may show an increased tracer uptake in the affected region. Additional information can be obtained from scanning with leukocyte labeled with gallium 67 and or indium 111. Computed tomography CT scanning can demonstrate calcification, ossification, and intracortical abnormalities. CT is particularly helpful in the evaluation of spinal vertebral regions. Ultrasonography is useful in children with acute osteomyelitis. This modality can detect abnormalities as early as 1 to 2 days after the onset of symptoms. The abnormalities include soft tissue abscess or fluid collection and periosteal elevation. The white cell count may be elevated, but it is frequently normal. The C-reactive protein is usually elevated, but this is not specific. The ESR is elevated in 90%, but this finding is clinically also non-specific. Blood culture results are positive in only 50% of patients, and hematogenous osteomyelitis may be associated with negative culture. I mean blood culture. Culture or aspiration findings in sample of the infected site are normal in 25% of cases, which means that we in some cases may need to do empirical antibiotic without isolation of the true organism. And finally, thank you very much for your attendance, and we will meet you in the next future with case quiz number 24. Wassalamu alaikum wa rahmatullahi wa barakatuh.